Afternoon, everyone. My name is Kendrick, and today I'll be presenting my confirmation of candidature presentation for my PhD project, which is entitled Artificial Intelligence in the Management of Metastatic Prostate Cancer, Automatic Segmentation and Radiomics Analysis of Gallium PSMA PET-CT Images. And this project is being undertaken under the supervision of Martin, Mubasher, Pejman and Roz. So prostate cancer is a major problem in the Western world, as I'm sure you're all aware. It's associated with significant patient mortality and morbidity. It's also the cancer with the highest incidence in males, so about 20,000 cases diagnosed according to 2019 data. And in terms of patient outcomes, early stage diagnosis yields quite high 5-year survival rates of greater than 90%. However, once the disease metastasizes, its lethality increases quite dramatically. So we see those 5-year survival rates dropping to less than 40%. And with bone metastases, which are some of the most common sites of metastatic spread for prostate cancer, they drop even further to about 10%. So it's a really pernicious disease. In terms of treatment options available, so surgery is a prominent treatment choice for localized prostate cancer. This is often done in the form of radical prostatectomy, where the patient's prostate is removed. But we know that between 20 to 40% of these patients will present with biochemical recurrence, with the possibility of developing subsequent metastasis. Radiotherapy is also a treatment option. This is typically used as an adjuvant to surgery for localized prostate cancer to reduce some of those recurrence rates, but it can also be used to treat individual metastatic lesions as well. So for example, bone lesions to the spine, the rib, etc. It's also used for palliative care. We then have more systemic therapies that sort of treat the lesions where they are throughout the body. So androgen deprivation therapy is one of the available options we have, and this treats it by reducing the hormones, so testosterone, that drives the growth of prostate cancer throughout the patient's body. And then of course we have chemotherapy as well, so targeting those rapidly dividing cells. And then finally we have PSMA targeted therapy, which are some of the newer therapies. So essentially what happens here is we have ligands that bind with really high affinity to the PSMA receptor, the prostate-specific membrane antigen receptor, which we know is vastly overexpressed in the majority of prostate cancer cases, and we attach radioactive isotopes to those to engender targeted killing of metastatic prostate cancer cells. So an example of one of the types of PSMA-targeted therapy is lutetium-177 therapy, which is a beta particle emitter, but there's also sort of newer therapies as well. Actinium-225 is an example, where this emits more damaging alpha particles. So it should also be noted that there can be combinations of therapies used as well. So for example, we have a trial ongoing at the moment, ENZA-P trial, which aims to determine if there's going to be a synergistic effect between enzalutamide, which is an androgen deprivation therapy, and lutetium PSMA therapy. But the issues are treatment response is highly variable, and almost invariably patients progress to lethality. And additionally, we sort of lack validated and robust biomarkers that can predict optimal treatment pathways for these patients. So it's sort of done in an ad hoc basis trial and error approach to see what sticks, but it's difficult to predict in advance what the best option available is for the patient. So this leads me to medical imaging. Medical images play a really important role in the management of metastatic prostate cancer, whether that be diagnosing its presence, offering a prognostic assessment of the likely progression of the disease, and also allowing us to assess whether a patient has responded to a treatment that we've given them. And in this space, gallium PSMA PET imaging is quickly becoming one of the most important modalities, again, because it binds with high affinity to that PSMA receptor that I was talking about before. But we know that in addition to these images being something that we can visually interpret, they are of course quantitative data, and we can analyze this data to yield both improved patient outcomes and also optimization of clinical workflows. So the question becomes, what do we mean by the term analyze? How do we analyze medical images? And one of the ways that we can analyze medical images is through a process called radiomics. So radiomics is defined as the extraction of large quantities of imaging features from medical images, and we use those features to yield useful diagnostic or prognostic information that can help our clinical decision making. And a typical radiomics process might proceed something like this. So the patient has their medical image, a PET, CT, MRI, whatever the case may be, and then we segment the area of interest from that image that we actually want to extract those features from. So this might be done in a manual, semi-automated, or fully automated way. We then undergo some post-processing of the image, so we might want to discretize it to discrete values so we can calculate some texture features, or we might want to resample it to isotropic voxel spacing, for example. And then we really have two different pathways we can take from there. So we have the traditional radiomics pathway, where we extract handcrafted features from that volume of interest. So we extract histogram, shape, filter-based texture features, etc. And we undergo a process of feature selection, so we're not overfitting the data set that we're training it on. So this can be done through a process of statistical thresholds, so excluding non-repeatable features, for example, which will become important later on. But it can also be done using data-driven algorithms like principal component analysis, which just reduces the dimensions of the data set that you're working with. And then you put those features into your final model to get the classification that you're interested in. Now, there's an alternative pathway, which has sort of come to fruition in the last maybe five to 10 years or so, which is deep radiomics. So this involves the use of deep learning networks to automatically extract features from the image. So instead of having to specify which handcrafted features you want to extract, these deep neural networks automatically learn the salient ones to extract from the image to undergo the particular task that you're interested in doing. So that brings me to the overview of this PhD project then. This is a high-level overview. So we have, the first aim is we have 180 bioclinically recurrent prostate cancer patients. And what we want to do is we want to use manual segmentations that have been performed on these patients. So each metastatic lesion has been outlined. We want to use those segmentations as the ground truth input to a convolutional neural network model, which is a deep neural network. And this is going to give us an automated lesion segmentation or detection framework. The second high-level aim is to use the same patient cohort that we have and to use both manual and automated segmentations that we've generated from the first aim, extract features from those lesions, and use those in predictive modelling tasks with respect to certain clinical endpoints, which I'll discuss in the later slides. And finally, we want to put these results in the context of repeatability. So we have, actually it's 18 PSMA test, retest examples. So the idea here will be that patients will receive a subsequent PET-CT scan approximately 2 to 3 days after their initial scan. We extract the same features from the images in both scans, and we ascertain the repeatability limits of each of these features. The idea here is that we don't want to be using features for treatment response or predictive modelling that change drastically between repeatability scans. So that's a high-level overview. Well, what does the literature say at the moment? What exists out there at this particular moment in time with respect to radiomics in metastatic prostate cancer? So first of all, we can divide it up into the three sort of areas that I've been discussing so far. So that's traditional radiomics, using those handcrafted features, deep radiomics, using the deep neural networks instead, and repeatability tasks as well. So the first one is traditional radiomics can be used for the prediction of metastases. So what this involves is radiomics models constructed from features extracted from a primary prostate cancer lesion, for example, and these can be used to predict the future onset of bone metastases, the future onset of lymph node involvement, or the presence of metastases throughout the patient body just using features extracted from the primary lesion. Secondly, we can use these features to classify individual lesions. So we might have a hotspot in an image that we don't know whether that's malignant or not. We can use these features to classify them. And one example is a study undertaken by Pekin et al., who used radiomics models to classify lymph nodes. So they segmented them, they classified them as either malignant or non-malignant, and they built radiomics models to do exactly the same thing. We can then use it for treatment optimization. So, for example, predicting which treatments might be best for a particular patient or even a particular lesion itself. So this can obviously be done at the lesion level as well. And in this respect, the literature is quite limited. We do have some studies, for example, Moazami et al., who just managed to correlate a few of those radiomics features, first-order radiomics features, with overall survival in lutetium PSMA therapy patients. But again, the literature is very limited in this respect, and this is something that I hope to add to myself. If we move on to the deep radiomics, it can be used for metastasis detection. So this is typically formulated as a multi-class classification problem. So you feed in your patient scan, the deep neural network then classifies that scan as either metastases absent or metastases present. So a binary classification. And this has been done, for example, in bone scans and F18 flucyclovine PET scans as well, in those two papers there. Again, we can also use it for lesion classification as well. So for example, for bone lesions or lymph nodes. And finally, we have the most difficult problem to solve, which is actual segmentation of the lesion. So rather than doing a classification problem, you want to actually get the exact outline of that lesion within the patient body. So this is the most difficult problem. It can be done in a number of ways. First of all is a semi-automated fashion, as in the case by Seifert et al. So they used a threshold relative to liver uptake, and then they trained a deep neural network to segment the physiologic areas of uptake within the patient body, subtracted the two images from each other, and then had a final person go through and manually edit that image to get their final segmentation process. So that's why it's semi-automated, because there's still some manual involvement. Alternatively, you can have fully automated methods of doing this. For example, Zhao et al. Did fully automated segmentation of gallium PSMA avid lesions, but they restricted their analysis just to the pelvic area. So again, this is something that I hope to add to with this PhD project. And finally, if we move on to repeatability, so repeatability has been assessed with respect to scan interpretation. So for example, Holbrook et al. Analysed the difference in TNM staging between gallium and fluorine PSMA scans and found that a minority of patients had a different TNM staging. It's also been done for first-order radiomics features. So for example, SUV max, these two studies assessed the repeatability of SUV max from gallium PSMA avid metastatic lesions. And what they found is that there can be quite a high variability between repeatable scans 2 to 3 days separate from each other. And finally, we have repeatability for higher order features. And to my knowledge, this hasn't been done. So the three sort of areas that this project is going to focus on are highlighted in red there. So we hope to use radiomics features for treatment optimization. We hope to develop a lesion segmentation framework, and we hope to assess the repeatability of higher order radiomics features in PSMA images. So if we take these aims sort of one at a time, we can go through each of them in a little bit more detail. So with the first aim, we have, like I said, 180 patients, gallium PSMA scans acquired at Charlie's or Fiona Stanley. 20 Fiona Stanley patients will be really valuable in terms of externally validating any predictive models that we develop as a result of this research. And patients had a baseline scan, and then 6 months later, they had a follow-up scan. And the treatments in that time period, they underwent treatments according to standard care. So this can involve radiotherapy to the prostatic bed, regional nodes or bone metastases, further surgery or systemic treatment in the form of chemo or ADT. And the inclusion criteria was just that they had to be biochemically recurrent prostate cancer patients. Now, the manual segmentation process that was done for this particular aim of the project was semi-automated in nature. So essentially what happened is the MIM workflow begins by applying a base global 3 SUV body weight threshold to the image. And this is then manually edited to remove any false positives, which are quite numerous, and to add in any false negatives that are missed during that process. So this does include lesions with an SUV max less than 3, but it's important to note that the observers weren't blind to the initial baseline scan when they were delineating the follow-up scan. This is important, as I'll discuss a little bit later, because it means that we might have to employ a potential dual model approach where we have a separate model for the baseline and the follow-up scans. And what's the significance of this? Well, first of all, manual segmentation is highly laborious. It takes a lot of time to go through an image and segment exactly where the lesions are in that image. It's also a prerequisite if we want to do any sort of feature extraction. So if we're looking to use radiomics for sort of treatment optimization, we actually need an outline of exactly where the lesions are within the patient so we can extract those features from it. And also, these deep models are deterministic. So there isn't any inter-observer variability. They'll give you exactly the same answer each time, whereas if you have a human do this process, there's a lot of inter-observer variability there. So the model that I utilised first was called the multi-res UNet. It's a UNet-style architecture that incorporates a few improvements from the original UNet. So for example, it has parallel convolution operations, which enables it to take in different scales of the image that is inputted. And it also includes convolutions in the skip connections as well, which enables further nonlinear processing between the encoder and decoder part of the network. This can be implemented in 2D or 3D. My initial experiments were with 2D, and it's implemented in TensorFlow, which is a popular sort of deep learning model building framework designed by Google. And in terms of pre-processing, the PET images were all converted into SUV body weight. PET and CT images were resampled to a common resolution. And because there was such a significant class imbalance, so you can see from the image there, this is just an example of one training instance. There's a significant class imbalance, which means only 2D axial slices that contain lesions were used to train the network. So these were my initial experiments, and I'll just take you through sort of everything that I've done so far and what the next steps will be and what we're actually implementing at the moment. So just bear with me. So the two-dimensional CNN results, we trained it on the whole data set. We inputted the PET-CT image as a dual-channel framework, and what we observed was pretty good training performance, so quite high dye scores and accuracy scores, which is just the weighted average of the sensitivity and the precision. But then once we tested it, those results declined quite precipitously, so we see pretty average dye score and accuracy score from there. And just an example of one of the really poor segmentations is given on the screen there. So this sort of led us to reevaluate our approach and think, okay, well, if there was a bias in the segmentation process, so if the observer was using the first scan to segment the second scan, maybe a dual model approach might be the better way to go. So the reason being, if the segmentation process isn't standardized across the two sets of scans, then this is problematic for deep learning because we're trying to train the model without giving it access to exactly the same information that that observer had when they were doing their manual segmentations. So we implemented the dual model approach. One model for the baseline scans, one model for the follow-up scans. And essentially, the results that we observed are that the training curve sort of proceeds as you would expect. So we're looking at the dye score on the y-axis and the number of training epochs on the x-axis. The training metric goes up exactly as you'd expect, but there's a really early divergence between the training and the validation dice. So what that means is that in the validation set, which the model doesn't have access to, when it's being tested on those examples, it's actually performing quite poorly. So again, we're seeing that it's not generalizing to a validation set. To rule out sort of random iterations being a factor, we repeated the experiment and didn't observe any significantly different results. So it must have been something else. The next step we took was to make the problem a little bit more solvable, potentially, and potentially isolate a cause of the poor results. We partitioned our data set even further. So we thought, okay, maybe the model isn't successfully segmenting both high SUV lesions and low SUV lesions that might be a little bit more difficult to pick up in the image. So we hypothesized that the variation in uptake values might be causing the poor results. So this is exactly what we did. We separated just the baseline scans into high SUV and low SUV examples. So anything above 3 was considered high, 3 SUV max. Anything less than 3 was considered low. And we observed pretty similar training curves when we do that. So exactly the same as before, training results increase as you would expect, but it doesn't perform any better on the validation set. And in fact, it performs even worse when you're considering just the low SUV lesions. So it definitely has a problem picking up low SUV lesions, but this is not the primary problem of why it's failing to learn. So, as I said, the experiments so far have been in 2 dimensions. So we've been only inputting 2D slices into our network and training it in that fashion. We thought, well, this is not taking advantage of the full context of the image that we're using. So we need a 3-dimensional approach, and this led us to the NNUNet. So we had a number of discussions with some collaborators in Wisconsin and New South Wales, and they suggested this as a good framework to use for 3-dimensional image segmentation tasks. And essentially what this is, it's an integrated framework that automates key aspects of the segmentation pipeline for you according to characteristics of the data set. So it'll automatically undergo voxel intensity normalization, resampling procedures, and will automatically generate 3-dimensional patches oversampling the foreground. So essentially what that means is it attempts to account for the class imbalance. So because the lesions are really small compared to the actual size of the image, it accounts for that by balancing that with the patches that it generates. So this is the approach that we're implementing essentially as we speak. It's training right now. And in terms of the progress on this, the data set has been pre-processed and placed in the specific format required by this framework. And you can see the required folder structure on the screen there. So we've converted the PET images again into SUV body weight, and we've resampled both the images to a common coordinate space as well. And training has been initialized on the 3D UNet cascade. So essentially what this means is that we train a first network. This is a low resolution 3D UNet, And what this is it increases the patch size relative to the size of the image, so that it has increased contextual information. And then the output of that is fed into the high-resolution 3D UNet, which is trained on the full-resolution images. So this essentially refines the segmentation map output by the initial one. And it automatically conducts 5-fold cross-validation for this. And so just as where we're up to, we've trained the first 2 folds of this. The third one is training as we speak. So essentially a week and a half, 2 weeks, because the training time is quite lengthy for these 3D networks. We'll have a working model that we can use and start building some metrics with. And in terms of the approach that I've used, so I've trained it on the full data set. Okay, so the assumption being here that providing more data to the model is often better. So this is pretty standard amongst sort of deep learning tasks. More data is better if the data is quality, of high quality. But I can modify this with relative ease by just inputting the baseline scans to account for that segmentation bias, and also separating the lesions according to SUV thresholding as well. So we have 324 total scans that we're working with. Training has been 209 scans, internal testing. So this will be Charlie scans that we're testing it on, will be 75. And we'll have an external testing set as well, 20 total scans from Fiona Stanley. So we'll be able to get a pretty good idea of how well this model actually performs. And we should be able to get this probably within the next month or so. So that brings me to the second part of the PhD project, the radiomics for treatment optimization. What does that actually mean? Well, as I was discussing before, patients in this data set have a baseline scan. 6 months later, following an intervening therapy, they have their follow-up scan. The idea here will be we want to extract features from the baseline scan, and we're going to use Radiomics, which is an open source framework for extracting radiomics features from images. It closely follows the Image Biomarker Standardization Initiative, which has a set of defined standards for features, and where it doesn't follow that, it clearly documents it. So this is the best way to produce reproducible research. And what we're going to do is we'll quantitatively characterize the lesions within the patient. We'll remove redundant features, so features that are highly correlated with each other, and non-repeatable features as well. So this will tie into the third aim of the PhD project. And we'll undertake some predictive modeling, and this will give us a predictive model that can calculate the probability of progression or response, both at the lesion and the patient level. And also correlation, we can undertake correlation analysis with the endpoints of the study. So for example, overall survival and PSA progression-free survival as well. And anything else we can get our hands on, although it has been difficult to get access to some of this information so far. So in terms of what does the predictive modeling concretely mean? Well, again, we have the 2 separate pathways that we can follow when it comes to developing the predictive models. So the traditional radiomics pathway, we've got our features, our handcrafted features. We can put them into a logistic regression model, gives us a probabilistic output of the training instance belonging to the positive class. We can use support vector machines, another machine learning type of machine learning model, which calculates the vectors in multi-dimensional feature space, which best separate the classes of interest. Or alternatively, we can use ensemble methods, so we can ensemble a number of different models together. We then, of course, have the deep radiomics pathway, so we can use artificial neural networks. These aren't typically used on images themselves, but they can be used on features. So we can actually extract handcrafted features, and we can use these artificial neural networks as our classification model at the very end. And then, of course, we can use convolutional neural networks, which work on actual images themselves, so we don't even have to worry about extracting those handcrafted features. And in terms of what sort of metrics we'll use to compare the models once we've built them, so we're going to calculate the area under the receiver operator characteristic curve, which tells us how well our model is classifying the positive versus the negative class. Now, this takes into account class imbalances. However, if there is a really severe class imbalance, we can calculate the area under the precision recall curve, and this just tells us how well the model is predicting the positive class. And of course, we can calculate our standard metrics as well, such as the precision, sensitivity, and the specificity. And when it comes to classifying lesions in patients, of course, we need to have a way of actually classifying them. So at the lesion level, we're going to have to match the lesions between the baseline and the follow-up scan and classify each individual lesion as responded or non-responded. Now, through the conversations that I've had with Jeremy in particular, he sort of mentioned that the best way to do this might be by classifying them by either a reduction in overall lesion volume or a reduction in SUV max between baseline and follow-up scan. But at the patient level, this problem becomes a little bit more difficult because, as far as I'm aware, there isn't a clinically accepted way of measuring patient response for sort of metastatic prostate cancer patients. And the reason for this is that a lot of patients fall into a mixed response category. So they might have an overall reduction in tumour burden between baseline and follow-up, but new disease sites that develop during that time period can be entirely dictating a poor prognosis for that patient. So it's difficult to classify a patient as respondent just because they've had a decrease in burden or a decrease in SUV max total throughout the body, for example, because of exactly this fact. So this is something that will need to be delved into, I guess, as the project proceeds. And this is just an example from a paper that was published earlier this year where they attempted to sort of rectify this issue. And what they came up with was they classified patients as either progressing or non-progressing, and they had subcategories for progressing. So if there was greater than or equal to 2 new metastases between a baseline and a follow-up scan, that was automatically progressing. 1 new metastases and an increase greater than or equal to 25% of PSA or blood biomarkers was also progressing, etc. So this is one way that we might be able to combat that, but the problem is quite difficult and we'll have to look into it some more. So finally, we have the repeatability analysis. The aim here will be to quantify the repeatability of radiomics features in gallium and fluorine-18 PSMA scans. We'll be doing this across all combinations of scans. So 5 patients had gallium to gallium scans, 5 had fluorine to fluorine, 5 had fluorine to gallium, and I think 3 had gallium to fluorine because we only managed to recruit 18 patients for the actual study. We'll be looking to add to this cohort if we can, because the paper published by Roef et al. Indicated that their data might be available. So we'll get in contact with them and see if we can add that to our data set. That was a gallium to gallium comparison. But as I said in the literature review slide, their analysis was limited to first order radiomics features. So the novelty in this project will be, we're going to extend that to the higher order radiomics features as well. So these results will help inform the appropriateness of the use of these features in assessing treatment response, for example, and they can also be used to exclude features from our modelling procedures in AIM 2. So the brief methods for this one is patients have a first scan, approximately 2 to 3 days later, their second scan. Total of 18 scans, like I said, the lesions will be manually segmented in each of these scans. In fact, they have already been manually segmented, just have to get the hard drive. A second observer will be really great for this because it would allow me to calculate feature reproducibility with respect to different observers. So what's the variability in these features compared to one observer to the next observer? And also we can utilise the working model from AIM1 to also segment these scans, and we can analyse the feature reproducibility with respect to the segmentation method. So not just the particular person, but whether it's manual or fully automated segmentation. We'll calculate the typical reproducibility metrics, so intra-class correlation coefficient, and a cutoff of about 0.8 to 0.9 is pretty typical in the literature to define a highly repeatable feature, and also the repeatability coefficient as well. So I just want to finish off then by describing this new sort of workflow that we envision as a result of this PhD project. So the traditional workflow is the patient receives their medical imaging scan, the image is reconstructed, and we have sometimes, if this isn't always the process, manual lesion segmentation, and then a team of clinical experts make a treatment decision based on the information that they extract from the image. So it's pretty straightforward. We envision this sort of AI augmented workflow where the first 2 steps remain the same, but then we feed our image through this artificial intelligence model. This gives us a fully automatic segmentation exactly where the lesions are within the patient. This is of course confirmed by an expert. We can't just rely on the results of the model. There needs to be human confirmation of it. and undertake lesion-level feature extraction to better characterize the underlying biology of the tumour. And these are, of course, in the context of feature repeatability. So we want to have the most repeatable features there, if we can. And then finally, we have treatment optimization. So better treatment choices for the patient, potentially identifying individual lesions which might be resistant to the therapies that we're planning to give them, and hopefully reduce workflow time as well. And I do want to stress the word augmented. So these models are not going to serve as a replacement for anyone. They are there to augment human decisions and help human decision making, and offer additions to human decision making, as in the case of calculating optimized treatment procedures. So just a quick summary of what's happened in the first year or so of this candidature. So myself and some colleagues have a publication in Frontiers in Oncology, which you can see on the screen there, and I've done quite a few presentations. Haven't actually fit all the presentations on there, but yeah, just a few presentations. These are the references that I used to create the slides today, and just want to thank everyone on the screen there for making this project possible and offering assistance when I asked for it. This definitely wouldn't be possible without all of your help. So thanks very much, and thanks everyone for listening. Yep.
So you've taken on quite a lot.
Yes. Yeah.
Because there's a lot of complexity in it. And I guess, as you say, one of the essential points is if you can't automatically segment the lesions, then it's difficult to progress beyond that because a lot of your other functions are very dependent.
True. Yeah.
Otherwise, you will be, I suppose you can rely on manual segmentation
Yeah.
and extract the function. So it won't be problematic from your PhD point of view, presumably. If you
Yep.
couldn't come up with an automated segmentation model, you will revert to looking at the features based on manual
Yes,
segmentation?
that's correct. Yeah, so we definitely can just use the manual if, hypothetically, if the fully automated segmentation framework doesn't come to fruition.
Reliably enough.
Yeah, or reliably enough. Even if it's not reliably enough, that would be a good result to sort of present anyway, because that would say that, okay, look, this is an extremely complicated procedure. Like, human brain is a very complicated thing to try and replicate with these models, right? So if we can't replicate it to sufficient accuracy or whatever metric we want to use, I think that's a valid result too, to be honest. But yes, we can revert to the manual segmentations to undertake our feature extraction as well.
Which is good because
Yep.
it's important that not everything is based on one critical thing not
Yep.
working.
Yep.
And so now that you're putting the 3D information into the neural network, does that include the PET plus the CT?
Yeah, so that's...
So it takes into account both?
Yes, yeah. So they're inputted as a dual channel. So essentially what that means is they're just an array with two channels, so PET, CT, and the image, the network incorporates that information when it's doing its training. So it does incorporate both, yes.
So it really though the 3D would actually have more of a chance of getting it right.
Yes.
Some of these structures, it's a difference between a spherical thing, which might be a tumour, and an elongated structure like a ureter or something that could be more of an anatomical shape. So
Absolutely,
I hope
yeah.
that with the 3D, that might give it a better chance of
Definitely.
to recognise the features that might be more typical of something not being tumour from tumour.
The results that I've looked at so far, just from the training curves, indicate that it is performing a lot better. But we'll have to wait until it's all finished before we do our testing to sort of give a concrete assessment of how well it performs, I guess. But yeah, all indications say it's performing better, but definitely just having a 2D approach, you're not taking any anatomical information almost at all into account especially in the Z direction, of course. So that was definitely a limiting factor as to why the results weren't as good as they could have been, I think.
Yeah, and I think it comes to the point also that when we do the PET scans, not everything
exactly.
That's why it's challenging. If it was
Yeah.
just a black and white situation that we simply
Exactly.
would have solved it before.
Yeah. If you could just apply a threshold,
Yeah.
that would be the
Well, we know
easiest
there's
way to go.
normal structures
But yeah,
that
exactly.
demonstrate some
Yeah.
activity. They're usually pretty typical, I think, of distribution
Mm.
or
They would hopefully be, yeah, exactly, sort of similar shapes and similar distributions across patients. And that way the network should be able to recognise that. So fingers crossed, we'll see. Yeah.
In regards to disease progression and deciding how many metastases indicates progress in disease as to the how much data do you have access to in making that decision? Because from my understanding, the literature is minimal on classifying that.
Yeah, well, you're exactly right. The literature is minimal. So we're probably just going to have conversations going forward as to how it happens at the patient level. But to be honest, I think the lesion level analysis is much more important and could more easily be sort of incorporated in the clinic. So the way I envision it is that we could, if we're planning to give this patient enzalutamide or something else, we might be able to predict in advance which lesions have a high likelihood of responding and which ones have a low likelihood of responding to that treatment. So we might be able to intervene early with a radiotherapy procedure, for example, for that particular lesion. That's the sort of thing that I'm thinking about. At the patient level, it's a lot more complicated, and I'm not really sure if it's as important as the lesion level analysis.
Yeah. So there's obviously retrospective patients
Yeah.
that have been treated and you've got their various clinical outcomes. How much data have you got post-treatment? Is it like, a year's worth of follow-ups, or is it a few months worth of follow-ups?
At the moment, we have 9 months worth of follow-up, so that's PSA data, but we're getting access to overall survival, so that will obviously be just until they pass away. And we want to get more PSA data if we can, so we're working towards it. Yeah. But at the moment, it's 9 months.
When you see differences between your model segmentation and user segmentation, do you always assume your model segmentation as well?
Well, it's a difficult one because we're relying on the accuracy of the manual segmentation. So if that's not accurate, then the model isn't going to be accurate. And essentially all we're doing is we're training it to replicate one person's idea of what a lesion looks like, right? So it's a difficult question. So it could be that they just missed that particular lesion, but that's not my decision to make. So I'm definitely not the expert in that area. So I'm relying on their expertise. If they think it's not a lesion, then it's not a lesion. Yeah.
It's interesting because you're saying about having a second person segment. It would be interesting to have a single person segment instead of twice.
Yeah. Yeah. Intra-observer variability. There is known to be a lot of that as well. So, yeah, definitely.
One of the challenges, Jake, may be that your data set, that trial, was on people who'd actually had negative conventional staging with CT and bone scans.
Yeah.
So it is likely that the majority of those patients actually have low burden of disease. So you're probably looking at a low burden of disease group, which may be actually adding to the challenge.
True. Yeah, that's definitely true. Yeah, if we had access to a higher burden patient cohort, yeah.
Recognising normal from abnormal, if any automated system is
Yeah.
going to be a lot easier. But the reality is, I guess this reflects prostate cancer that actually.
Exactly. Yeah, you want it to
can't
be.
just say, oh, we can only pick up the ones with lots and lots of lesions.
Yeah. We don't want to exclude the patients that we know exist clinically.
Yeah.
It just doesn't make any
It's a
sense to
real
do that.
nice
So,
data set that
yeah.
You've got a real clinical problem,
Yeah.
I guess, and we face
and we'll
all the
see if
time,
it can be
but
solved.
it's not a high burden of disease
Yeah.
data set.
That's a good point.
Can you please check on Zoom?
Yep. Does anyone on Zoom have any questions? I'm trying to look at the chat, but it's not coming up. Okay. Well, thanks everyone for listening. Oh, there is something in the chat. Okay, yeah, no questions yet.